Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today, I'm joined by Professor Isabella Anasi Massano to discuss her latest paper entitled Natural Disasters and Respiratory Health. Professor Anasi Massano is the NIH Research Director and Professor of Environmental Epidemiology at the University Hospital Institute, Immune for Cure, French NIH, and University of Montpellier in Montpellier, France. Isabella, many thanks for joining us today.
Thank you for having me, Don.
Isabella, your paper, Natural Disasters and Respiratory Health, is a must-read for patients, clinicians, and public health makers interested in respiratory medicine. Over the past few years, we have had major natural disasters across the world, including the 2023 Turkey-Syria earthquake, 2022 Hurricane Ian, which affected Cuba and U.S., 2022 flooding in Pakistan, and 2024 wildfires in Canada and some parts of Europe. Isabella, do we have a sense of their impact specifically on respiratory outcomes, both in the short term and the long term?
The natural disaster you are mentioning, mainly storms, floods, earthquakes, a wildfire, to quote the most important, not only destroy homes, but also harm breathing, because they increase the exposure to harmful particles, allergen, and other stressors, and this in difficult and precarious situations lead us to measurable increase in hospitalization and in vulnerable groups to mortality. Wildfire cause sharp increases in hospitalization and emergency visit for asthma, COPD, and respiratory infections due to high level of these fine particles of diameter less than 2 micron and half and toxic gases. In some events, this is the case of the Australian fire in 2019 and 2020, or in Canadian fires that in 2023, hospital admission rose by 10 to 30%. This is really evidence-based with publication in peer-reviewed journal during peak smoke exposure. But we have also data on floods. These are associated with increase in the respiratory infection. As a respiratory doctor, for us, water is different from air, but actually is dangerous also. And so more respiratory infection, more pneumonia, and exacerbation of chronic lung disease like COPD, largely due to mold growth, humidity, and also, unfortunately, in vulnerable people, displacement condition. A study show a 5 to 10% rise in respiratory hospitalization within weeks after major flooding. Another example were in USA. So also these are data that are really well documented. Regarding long-term effect, I'm an epidemiologist, so I have to be cautious. Although emerging evidence indicates that this natural catastrophe can significantly increase this morbidity and mortality in the long term, because they are at the origin of irreversible damage. From the epidemiological point of view, robust quantitative data remain scarce because we need to follow up people. And indeed, this scarcity reflects the logistical difficulties of following affected population, as displaced individuals often relocate. The houses have been destroyed. There is no more possibility to stay in the same place. People obviously move, making as a whole long-term health monitoring and data link challenging. But we have good data from the Las Palmas volcano eruption in Canary Island, because our colleagues were very good. They assessed it just during the eruption in population around the volcano, and then now they are following them. And the first paper was published, I think, showing already differences in lung function and respiratory symptoms. So obviously we need more data like that, and also methodologically speaking, we need tools to follow up individuals that have been exposed to natural catastrophe.
Let's hone in on harmful particles that you mentioned. They're sometimes called PMs, PM10, PM2.5, ultrafine particles. Can you just discuss a little bit about the harmful particles and their potential mechanism by which they cause harmful respiratory outcomes?
Yes, PM are the killers. They are particles containing many things. 2.5 are those that can enter in the airways and deeply, and the largest stay in the upper part, and the very tiny, they can go actually enter in the blood circulation. But they trigger oxidative stress, inflammation, and immune dysregulation, which amplify existing airway and parenchymal injury. So in patients who have already the disease, COPD, asthma, or idiopathic lung diseases already compromised, this leads to exacerbation, faster disease progression, higher mortality. And there is also the so-called systemic spillover that deserves to be reminded. These ultrafine particles, less than 0.1 micron, so very, very small, and with also cytokine of the inflammatory process, can enter blood circulation by passing the alveoli barrier, and then they are in the blood and they touch other organs, and so contributing to systemic inflammation, endothelial dysfunction, and increased cardiovascular mortality. And we have this ultrafine where, for example, in volcanoes, in wildfires, and many others actually, but mainly they are characteristic of these catastrophes.
Can patients protect themselves during these natural disasters, such as wildfire, by wearing masks, like surgical masks or N95 masks? Are there any evidence that these masks protect patients?
Yeah, there are data from USA, American Thoracic Society colleagues, EPA also saying that not really the surgical mask, but the 95 or FFP2 mask, this can protect. Obviously, it's not 100% protection. We have learned this during the COVID epidemics, but this is important. I should say that we need patients have to be informed. They have to stay indoors. They have to understand that it's important to filter the air to maintain optimal disease control. Globally, this is one publication. These simple steps can cut particulate exposure by 50 to 80%, which is not bad, and also reduce other pollutants exposure, thus at least prevent severe exacerbation. But obviously I need to be cautious because I would like to have more data, double blind, placebo, etc.
So the bottom line is when the air quality outside is very poor or with increased PM content, patients are advised to stay indoors, close the windows, turn on the air filtration system. If they don't have one, they should purchase one with an N95 filtration system at the very least, and use their inhalers if necessary. Would that be the right offering for patients?
Yeah, I think these steps are important. Obviously, we have to take in mind that some people cannot buy and some people are not informed. So we have a role to play as a respiratory doctor to inform our patients about what they have to do. And also, obviously, the authorities, obviously, they have to play an important role to be more in contact with the population.
There's a very interesting section in your paper entitled Thunderstorm Asthma. Could you describe what this is and what asthma patients should do during thunderstorms?
Thunderstorm asthma is really a striking example, emblematic of how climate weather interact with allergic diseases. Actually, it refers to sudden widespread asthma attack triggered by thunderstorm. What happens? Thunderstorm aerosolizes allergen like pollen and molds, turning normal non-respirable pollen, because pollen are large in size. They stay in the upper part of our airways. And because of this aerosolization, pollen grains and mold spores become lung penetrate respirable microparticles. So they can reach the lower airway. And when this happens in people, they are suffering from rhinitis or have just some bronchoconstriction every now and then, they can be at the origin of huge asthma attacks, very severe asthma attacks. And this is very stressful because people never had that. There was a very famous event occurring in Melbourne, Australia in 2016, where there were over 19,000 emergency visits for asthma attacks. 9,000 emergency visits. You cannot cope with that because of the number. To reply to your question, what do? They have to adhere to asthma medication, stay indoors during storms in pollen season. People with rhinitis have to stay indoors. Also, when there is a mold dispersion in dry zone because of the wind, because it's the wind before the rain that is the origin of these allergens, these aerosols.
Any last words regarding your paper or about environmental health in general that you would like our audience to know about?
I would like to stress, first of all, that we are talking about my paper. This was a really collaborative paper with many colleagues working in not all the in age, but since ever colleague working on environment, respiratory health that helped to write this paper. But I want also to stress that these natural phenomena are increasing due to global warming and the climate change. And we need, this is the last part of the paper, urgently to quantify and mitigate their hidden toll on respiratory mortality hospitalization. And I can finish with 3 concise policy clinical takeaways. We need to measure the event in a systematic way. We need to protect the vulnerable because they are more exposed than the others. And also, I always insist on that, integrate health into disaster planning. And then as just a final message, I talk all the time about the avoidable exposome. So we really need to reduce air pollution emission, and the WHO Global Conference on Air Pollution and Health finished with 50 million people declaring that it was really important to reduce air pollution to protect human health. And in this reduction, obviously, we have to include also natural catastrophe. In some countries in Europe, pollution from a natural catastrophe is not taken into account. So can you imagine, you can have a lot of pollution, but this is natural, so it doesn't count. Yes, it counts, because we are the origin, and also because we need to protect people.
On those very important points, we will conclude our podcast. Professor Anna Masano's full paper is now available on the ERJ website. Thank you for joining us today.
Thank you.